Assalamu alaikum dear students, my name is Farouk Aslanov. I'm a PhD assistant of Physiology and Tuberculosis Department of Bukhara State Medical Institute named after Abu Ali ibn Sina. Topic of our presentation is about tuberculous meningitis, and this presentation dedicated for the students of General Medicine faculty. Tuberculous meningitis, specific lesion by Mycobacterium tuberculosis of the meninges, soft, arachnoidal, and less often hard meningeal layers of the brain and the spinal cord. Tuberculosis of the spinal cord, spinal form of tuberculous meningitis can cause complication of the basilar meningitis. It is characterized by an extremely severe clinical courses. General provisions. General provisions combined with the tuberculous process in the lung or intrathoracic lymph nodes in 50% of cases. Tuberculous meningitis very rarely could be primarily, but mostly we can meet after some kind of tuberculosis in other organs. One-third of them occur against background of disseminated tuberculosis after, for example, miliary tuberculosis. On this presentation, you can see the X-ray, CT scan, and MRI of these several organs. So this is same patient's examinations. On first picture, we can see the inflammation located in the respiratory system. So in the lung, we can see widespread process in both lung and pathological focuses located symmetrically in both lung. So this case we call as miliary tuberculosis by the word millet. On CT scan of the lung, we can see the hundreds or thousands of focuses, similar focuses by the size 1 to mm by the affecting both lung. On X-ray, we can see pathological process on the vertebra, scoliosis, and the brain of the patient. We can see not only meningitis occurred, but encephalitis too. There are a lot of inflammatory process in the brain tissue, encephalitis too. Pathogenesis, as I have told you in previous lecture, in previous slides, could be primary and secondary. In secondary genesis and in primary genesis, the ways of distribution of infection could be occur by hematogenous way, by lymphogenous way, and by the liquorogenic way. Here we can see the illustration of pathogenesis of tuberculous meningitis. So on A picture, it's shown the host inhales aerosol droplets containing Mycobacterium tuberculosis bacilli. Within the lung, the bacilli may infect the alveoli macrophages, resulting in the formation of granuloma. The bacilli may then escape from the damaged granuloma or from the lung during primary TB, causing bacteremia, resulting in hematogenous spread of the bacteria into the brain. In B picture, we can see extracellular bacteria, and the infected cells may migrate through the blood-brain barrier into the brain. Once in the brain, the bacilli infect microglial cells, which then together with infiltrating cells release cytokines and chemokines, leading to disruption of the brain-blood barrier and influx of other unaffected immune cells into the brain. In C picture, we can see the results in the formation of the granuloma, focusing. And in D picture, when the rich focus ruptures, the bacteria release it into the subarachnoidal space by leading to dissemination of infection. This next slide shows another illustration of the pathogenesis. So here we can see on the right side the changes inflammatory process in the brain and the brain membranes. The clinical picture depends on several factors. First of all, the process localization process. Second one, the nature of the exudate. Third one, the speed of its accumulation. Fourth one, individual reactivity of the body. Pathomorphology of the basilar meningitis. The meninges are sharply thickened and muddy. The exudate cirrhosis has gray-yellow or yellow jelly-like appearance. Tuberculosis. Along the olfactory nerves in the area of the intersection of the optic nerves on the contact surfaces of the frontal lobes. The ventricles are dilated, contain muddy exudate. On the ependyma of the ventricles there are small tubercles. Basilar meningitis. This is most spread type of meningitis. Basilar meningitis consists of 3 periods. First period we call as prodromal period of prodroma. The duration of prodromal period is from 1 to 4 weeks. During this period of prodroma, patient can complain to fatigue, irritability, drowsiness, apathy, loss of appetite, headaches aggravated by bright light and noise, temperature rises for 1-2 hours up to 38-39 degrees. Second period we call as period of the peak of the disease. The duration of second period is about 1 or 2 weeks. In this second period, we will notice increasing of symptoms of the prodromal period, and headache becomes constant. Constant headache, it means we cannot suppress this headache by some kind of non-steroidal or steroidal drugs. So, and in second stage, we can be evidence the development of meningeal syndrome, neck stiffness, Kernick signs, and Brudzinski symptoms. Additionally, in second stage, we can notice the functional failure of several cranial nerves like third nerves, oculomotors, fourth nerves, trochlearis, sixth nerves, abducens, seventh nerves, facialis, eighth nerves, glossopharyngeus, ninth nerves, eighth nerves, vesiculocochlearis, ninth nerves, glossopharyngeus, 10th nerves, vagus, and 11th nerves, accessorius. So after damaging the cranial nerves, patient starts showing problems relatively to these nerves, like problems with the swallowing, dysphagia, choking when eating, aphasia or dysarthria, hiccup, respiratory or pulse disorder, and glossoplegia. Third period is terminal period. This is last stage of tuberculous meningitis. The duration of third period is about 1 to week 2. Period of meningoencephalitis. What kind of symptoms we can expect from the patient? First of them is pyramid signs, paresis and paralysis, lower monoparesis and paraparesis, vasculitis and rash of tuberculosis, endarteritis and thrombosis of cerebral vessels, and development of ischemic strokes. By the end of third week, we can see again exhaustion of develops, bed sores appear, paralysis of the respiratory and vasomotor sensors. Here you can see the micropreparation of basilar tuberculous meningitis after the death of the patient. So tuberculous inflammation fully damage the basilar part of the brain, basilar part. Here we can see inflammatory process. Second type of meningitis is spinal meningitis. By the end of second week of the prodromal stage, we can see again symptoms of spinal tuberculosis, spinal meningitis. The symptoms of spinal meningitis are girdle pains, pain along the spine, and radicular pain. These symptoms are early symptoms of a developing blockade of the cerebrospinal fluid pathways. Signs of the liquor block: xanthochronic cerebrospinal fluid, protein cell dissociation, high protein content with slight pleocytosis, 60 and 80 cells in 1 ml of cerebrospinal fluid. With the predominance of the pyramidal symptoms, lowered paresis we can see. Dysfunction of the pelvic organs like urinary retention or incontinence, difficulty defecation, leg reflexes are higher. Diagnosis. For diagnosis of spinal tuberculosis, meningitis, we should do analyze the development of the disease, characterize it by subacute development of the disease, find out if there is tuberculosis in the other part of the body. We should carry out a liquorological study, and we should examine the ocular fundus. Changes in liquorological study. First of all, we should know the normal pressure liquid in cerebrospinal channel. In norm, it is 100 up to 200 mm, but in tuberculous meningitis it is more than 200 mm. The amount of cells in the cerebrospinal fluid. In the norm moments, the amount of cells up to 10 cells in 1 ml. But in tuberculous meningitis, the amount of cells will increase up to 200 to 400 cells. And mostly, it is predominantly lymphocytic cytosis. Total protein in norm condition, the percentage or the amount of protein up to 0.3 gram in 1 liter. In tuberculous meningitis, it is increased up to 3 gram in liters. With spinal forms of meningitis, it could be reached till 30 or 60 grams in liters. The amount of glucose decreased. The amount of chlorides is to decrease it in tuberculous meningitis. Fibrin membrane formation. In normal, cerebrospinal liquid, it's absent. But in tuberculous meningitis, is formed when the cerebrospinal fluid is left standing for a day. On average, in 40–50% of patients, we can see this membrane. The presence of MBT in cerebrospinal fluid in 10–20% of patients when using both bacterioscopy and culture method of diagnosis. By checking ocular fundus, in 50% cases of patients, we can see edema of the optic discs. In some cases, we can see specific tuberculous chorioretinitis. Here you can see the autoscopic macropreparation of basilar meningitis. This is another method of diagnosis with the damaging of cranium bones and the central nervous system by causing meningitis and encephalitis too. Treatment. For treatment, we should use, of course, antituberculous treatment. Antituberculous treatment, in the intensive phase of treatment, we should use 4 component drugs: isoniazid, rifampicin, pyrazinamide, and ethambutol. In the maintenance or in supportive phase, with the duration of 7 months, just 2 or 3 drugs, isoniazid or rifampicin. And additionally, we should perform pathogenetic therapy, corticosteroidal treatment, dehydration for prophylaxis of edema in the brain, and we should do lumbar puncture. Forecast prognosis is very bad, mostly because meningitis, yes, it's very rare disease, but prognosis, if we will not start as soon as possible, the chance of lethality higher than other forms of tuberculosis. Thank you for your attention.